Let me just double check. Let's get things going, and we are recording, which is fantastic. That's all. That was my cue, actually. I missed my cue, I think, there. So for those who don't know me, my name is Hannah Crouch and I'm the editor at Digital Health. Like I said, thank you to everyone who is joining us for today's best practice webinar, which is going to be focused on the Greater Manchester Care Record, a year on since it was deployed across the region. The record involves a number of bodies such as the Greater Manchester Health and Social Care Partnership, the 10 Greater Manchester localities, Health Innovation Manchester and technology provider Graphnet. I think I said Manchester quite a few times then. Over 500 health and social care organisations provide data into the GM Care Record, with 10,500 care professionals using it every month. So a year after it was deployed, how's it all been going? Hopefully within the hour, we'll all be in the know. So today you're going to be hearing from Dr. Paula Bennett, who's the Associate Director for Clinical Development at Health Innovation Manchester, and Guy Lucci, who's the Digital Innovation Director at Health Innovation Manchester as well. After our presenters have spoken, which should be sort of around 30 to 40 minutes, we're going to have the main Q&A session. Those with questions, just a reminder, you can ask them at any point during the webinar. So if anything flags up when someone is speaking, you can ask it whenever. The best place to do this is in the Q&A section. Please do put it in the Q&A section so it's much clearer. And you can also vote for your favourite questions. So if you see a question that you like, give it a thumbs up and it will bump it up my list when it comes to the Q&A session. And if you would like your question directed at someone in particular, say if it's Paula or Guy, please let me know and I can direct it to them, or it will just be a free-for-all. I'm now going to stop talking, I promise, and I'm going to hand over to our presenters. Guy, I believe you're up first, so please take it away.
Great, thanks very much, Hannah. Hopefully everybody can hear me okay. So yeah, just as a brief way of introduction about myself. So I've got two roles. I'm actually head of digital innovation for Health Innovation Manchester. I'm also head of digital for the Greater Manchester Integrated Care Organisation. As well as a sort of brief background, I'm born and bred in Greater Manchester, went to university in Salford and spent 25 years of my career working for a global tech company, helping shape and lead some of the largest and some of the most complex digitally enabled healthcare transformation programs in both the NHS and across the world. Through this experience, I've seen at first hand the power that digital can bring to bear in addressing some of the wicked challenges we have in healthcare and in turn improve patient outcomes. That said, I recognise there's two ingredients for success that I've certainly learned through my career. One is you need to gain absolute clarity on the problem before focusing on the tech. And the second, the solution to the problem is much broader than the tech and involves people, process and cultural change to be successful. And my simple rule of thumb is if you spend £1 on the technology, we should be spending £3 on the business and clinical change. So while I was working for this global tech company, I always felt one step removed from truly understanding the problems being faced at the front line and the ability to really champion the people, process and cultural change required. And for that reason, I decided to step out of working with industry and have now the honour of working for the NHS in Health Innovation Manchester. And I've been in post for about 2 years. Next slide, Peter. Great. I'm just going to give you a brief pen picture of Greater Manchester. And like many regions, both in the UK and across the world, Manchester's got a diverse population with a range of complex needs, similar, as I say, to many parts of the world. We've got below average life expectancy for both men and women. We've got an ageing population and children that are facing diversity in their early years. This is all at the same time that public services are faced with unprecedented demands and stretched resources. So GM leaders recognised that the poor health of the population was actually preventing people from being able to work, which was impacting on economic growth and prosperity. And therefore, in 2016, GM became the first fully devolved city region, which was a major catalyst for change. Through devolution, GM leaders have now got delegated responsibility for the £7 billion health and social care budget, and through integrated commissioning at the city and locality level, we have the ability to commission and deliver different types of services. Next slide. Great, thanks, Peter. So Health Innovation Manchester was formed to directly respond to the challenge of poor population health. We work at the intersection between health and care, academia and industry, and our role is to discover, develop and deploy new innovations into frontline care to improve the health of our 2.8 million population. Over the last 2 years, in particular, we've focused on developing our innovation pipeline approach to deliver transformational change, which has given us a deep understanding of citizen need and taught us to clearly define the problems we need to solve, and then co-creating innovative solutions to address those problems, often in direct partnership with industry. We've also evolved our operating model to ensure we have the right blend of skills and capabilities needed to operate a digital office that provides digital strategy, design, development, and deployment expertise across the whole of the GM ecosystem. From a digital perspective, we've refreshed the health and care digital strategy for Greater Manchester to ensure it's absolutely subservient to the NHS long-term plan and our local industrial strategy. We've established a digital transformation board comprised of clinical, provider, financial and digital leaders across the system to ensure that digital is really owned at the top of the shop. We've co-created an integrated care system, a digital investment and maturity framework, which has helped us really identify the programs of work that will deliver the greatest value. And working with over 120 stakeholders, including patients and publics, we've really got a consistent buy-in to that framework and therefore the priorities of the digital investments that we're making. Next slide, Peter. Yeah, so in terms of the GM Care record, which I'll come on to talk about in a second, it's probably just worth reflecting around our response to COVID-19. Obviously, the pandemic has taught us to work and operate in completely new innovative ways, and digital really has been a sort of forefront enabler to help us address that challenge. So one of the key things that we did when COVID-19 actually hit was sort of refocus our digital priorities, and I just want to share with you some of the things that we've done over the last 18 months. Next slide, please, Peter. So a huge amount of work has been done over the last 18 months in GM to address in response to the COVID-19 pandemic. I'll just pull out a few key examples. We've set up the Nightingale Hospital. We've supported remote working for hundreds of thousands of staff. We've set up virtual consultation, both in primary and secondary care. We've accelerated the GM Care record, which I'll come on to talk about, for both direct care and population health. We've developed a digital platform to support GM stop smoking services in pregnancy, which is interestingly shortlisted for HSJ Ward this week. We've deployed a digital platform to care homes to support the remote monitoring of care residents. We've delivered emergency care by appointment to enable a GM clinical assessment service and to enable GM clinical assessment service to support direct booking in A&E services. And we've deployed a range of tools to support at-risk groups with mental health challenges. So a huge amount of work that's gone on in the digital space. Now, as we zoom into the GM Care record, Peter, if you go to the next slide, please. Okay, great. So as I say, the GM Care record has really been a pivotal digital asset that really has helped us address the challenges around COVID-19. And in terms of what the GM Care record is, it is an integrated care record for GM patients that brings together patient data from GPs, from community, secondary care, mental health, specialist services, social care, NWAS into a single record, and it brings all that information together to provide a view of the patient's key medical and social information, including diagnostic information or diagnosis information, medication, test results, hospital appointments and attendances, care plans, end-of-life wishes, and social care packages. So what does this mean for patients? Well, clinicians have easy access to all patient information, essential for the decision making, so they can make the best possible decision about the care of the patient. It provides multi-agency care planning, so we have consistent visibility of complex patient need across different organisations. Clinicians are better equipped to identify patterns and plan care and more effectively to meet patient needs. And from a patient perspective, patients don't have to keep repeating their story and medical history to each professional in each organisation. So a huge impact in terms of providing the tools to enable better clinical decision making at the point of care. Next slide, please, Peter. So, as I say, we've really accelerated the use of the GM Care record over the last 18 months. So if I just sort of give you a pen picture of the situation before COVID hit. So before COVID hit, we had around about 2 million patient records within the GM Care record. We now have all our 2.8 million patient records now on the GM Care record. There was also walls in the data. So what I mean by that is that if you were a Salford clinician, you could only see patient records from residents or from Salford. You couldn't see a patient record from Manchester. So we've removed all those walls in the data. We've also accelerated the deployment of the GM Care record into all clinical and social care settings, which has driven user access to a completely different level. And you can see from the statistics that you see on the slide that we've really driven user growth. So we've increased clinical usage and operational usage by twice in terms of the number of users. You can see by the number of logins that we receive that there's been a huge acceleration in terms of the people that are actually using the GM Care record. So a massive acceleration in the use both for direct care and also for secondary usage. So we are currently operating around about 20 research projects using the very deep and rich data that's held within the GM Care record. And we've got a specific video that touches upon some of that as we go a bit further forward. Next slide, please, Peter. Okay, great. So in addition to sort of accelerating the use of the GM Care record and completing all the data feeds to create the broad and deep clinical record for each of those patients, we've also done a number of other key and major shifts over the last 18 months. One of them is to move from 10 individual contracts that supported the GM Care record into a single citywide contract. And in that process, we're also moving from an on-premise solution to a single solution hosted in the cloud. I've talked about the acceleration that we've made in terms of patient growth. And the other key element that we've done is that we're moving away from separate data controller agreements into a single data processing agreement across the whole of Greater Manchester. Now, this is wouldn't underestimate the effort that it's taken really to enable that to occur, but a huge win in terms of reducing complexity around data sharing. And fundamental to achieving that success really is the governance that we've put around the operation of the GM Care record. So we formed a secondary usage and oversight committee that has public and patient engagement, as well as engagement from all the universities and all the data controllers and processors of the GM Care record. And that particular group provides oversight and governance for every use of the GM Care record, both from a secondary care perspective and a direct care perspective. And that's been absolutely fundamental in providing oversight and building trust with each of the data controllers as we've moved from 10 individual contracts to a single contract, and from 500 data processing control agreements to a single data processing agreement. And that's going to be a fundamental building block as we move away from the coping notice in the coming months. Next slide, please. Great. So now I just want to share with you, share with you some of the other key transformational programs that we're running on the GM Care record. So just to recap, what we've done over the last 18 months is really enable the data exchange to be fully enabled across Greater Manchester. We've removed the walls and the data to ensure that everybody can have access to that. We've built an information governance framework, so we've simplified data sharing. And as part of that, that's really enabled us to provide a digital platform that's ready to go one step further and be a real asset in changing pathways and transforming care. So on top of that platform, over the last 18 months, we've launched a number of additional capabilities. We've launched our COVID-19 oximetry at home remote monitoring application. So this is where a patient that's at risk of long COVID or is at risk of deterioration, they're prescribed an application, a mobile application, and they're given a set of blood pressure and OT instruments, and the patient then actively reports those readings on a daily basis. Those readings then go into the app, and those readings go into the GM Care record, and then we have a clinical service that actively monitors those readings, and if we see a patient deteriorating, we reach out to that patient. Similarly, we're developing a integrated multi-agency heart failure care plan for those people that suffer from heart failure in Greater Manchester. Indeed, 28,000 people in Greater Manchester have heart failure. So having an integrated heart failure care plan that's got visibility of the goals and symptoms for heart failure that's shared between secondary care, community care and primary care is fundamentally key and important. We've also launched a remote monitoring application for pregnant ladies that are at risk of preeclampsia and gestational diabetes. So again, very similar to the COVID Oximetry at home application. Specific readings and symptoms are recorded by the patient on a daily basis, and they're reviewed clinically. And if there's any signs of deterioration, the clinical staff actively reach out to those individuals. We've integrated the GM Care record into NWAS. So NWAS which is the Northwest Ambulance Service, have got direct access to the GM Care record, so they can see at the point that somebody phones 999, they have access to the GM Care record to see the medical history. And we've also got the ability to share specific details of specific patient notes, which are critical for emergency care decision making. We've also integrated our COVID-19 care home application. So this is an application that monitors the soft signs of deterioration from residents of care home. That information is routed into the GM Care record as a tile, and then clinicians that are monitoring a digital hub in each locality are able to check in every day to see the state of specific residents, and if appropriate, then reach out to the care home to speak to care home staff around potential deterioration of those patients. A lot of work has been gone on around integrating the Christie cancer information into the GM Care record, and finally, we're just in the early stages of deploying an integrated frailty and dementia care plan on the GM Care record. And again, this will be a multi-agency plan that has visibility across the care settings in terms of primary, social care, mental health, acute care and specialist services. And also in that piece of work, we're doing some really interesting integration into GP systems to enable read and write of that data back into the underlying GP system. So huge sort of transformation that's gone on over the last 18 months. And I think, Hannah, I'm going to hand over to the presentation, the video next, that brings to life some of the research studies that we've been operating on the GM Care record. I think it's good to say that in terms of just to provide you some further context. So as part of the GM Care record, we've also got an analytics a database that hangs off that GM Care record. To give you an understanding of the scale of the data, I think we've got around about 6 billion rows of data, so that's 6 billion rows of rich data. So you can imagine the huge sort of insight that we can gain by analysing that data. So we've now through agreement with the Secondary Uses and Oversight Committee, And through the IG framework that we've established, we've now got a robust mechanism by which we can agree research studies against that data with full public support and transparency, and full support from each of the data controllers, and which in turn has enabled us to launch the 20 research cases that are currently operating on the GM Analytics platform as we speak. So with that context, I'm going to hand over, I think, to play the video, and you're going to hear from Niels Peak, who is the digital lead at Manchester University, to share some of our experience in that area. Thank you.
I lead the program of work that enables university researchers to use patient data from the Greater Manchester Care Record for COVID-19 related research. What's unique about the GM Care Record is that it's about all citizens from one locality. And that's not true for any of the other data sets that we have. So this enables us to do place-based research and place-based innovation and use the results from research directly to improve the health and health services in Greater Manchester. It's really important that we make sure that we protect the privacy of the citizens that are described in the Greater Manchester Care Record. And this is obviously something that I care about myself as a citizen as well, because I know that my data are in there. So what we do is, before we as researchers see the data, anything that could possibly identify a person, a name, telephone number, NHS number, address, all of that is stripped out of the data before we see it. So that means that the data are reduced to a set of codes that is entirely anonymous. It's good enough to do the research, but it could never be traced back to an individual. So at the moment, we're using the Greater Manchester Care Record only for COVID-19 related research, and it's been tremendously valuable to do that, to answer all those questions that we have around COVID-19. But I do hope in the future we can also use it for other questions, because we have so many more questions, especially in Greater Manchester, where we have so many health inequalities. There's lots of things that we need to explore further, because all of that can then help us to create better health policies in the region, and with that, better health for the Greater Manchester population.
Okay, turn myself off mute, it's over to me now. Just a brief introduction. My name's Paula Bennett. I'm an emergency nurse and the Associate Director for Clinical Development at Health Innovation Manchester. So I've had a long clinical career in emergency nursing, so 26 years, the last 12 of which as an emergency nurse consultant. And during that time, I had the exciting privilege to develop an EPR from scratch and a patient tracking, a digital function for patient tracking, and launch that, and also undertake research on the quality and safety benefits of it. So lots of hunches at the time that it would make care better for patients and it would make care easier for staff to deliver. And I was able to demonstrate that through primary research, and it was from that that I wanted to do more work in this field and move to work in Health Innovation Manchester 5 years ago. And then for probably the last 2 years, I've been very much involved in the developments with the GM Care Record. And I'm going to build on the kind of strategic picture that Guy's painted and just look in detail over the next 10 minutes. There's about 8 slides that look at some of the clinical benefits, some case studies and some data around how the usage of the GM Care Record and lifting all those artificial locality barriers in Greater Manchester has made care better and safer for patients and easier for staff and carers to deliver. Next slide, please, Peter. So there's a lot of information on this slide. It's my clinical background, so I'm really used to the frustrations of not understanding the full picture when a patient presents in an emergency. and in an urgent or emergency care setting. So we look specifically, because we're now sharing data across the whole of Greater Manchester, to understand how many patients are really going to be benefiting, and how many clinicians are going to be able to save time because they haven't got to make a phone call to a GP practice, to wait for the telephone to be answered, for somebody then to hunt out the information in a record and communicate that back. So just across the top of that slide, sharing data across Greater Manchester means that frontline clinicians in emergency departments, in walk-in centres, in acute medical settings have got access to the records for the patients they're caring for, but not just their local patients. So you'll be aware that patients may live on the border, they might have a GP registered in one locality, but visit their local emergency department might be nearer to them than their local CCG. But lots of patients move around Manchester. We've got the Christie Cancer Hospital, and then we've got tertiary referral centres. So we identified the numbers of patients you can see from the table on the right hand side per hospital site, the final column on the right, the average number of patients per day that attend those emergency departments that are out of area. That before the pandemic and before we increased the data sharing, that information would not have been accessible to frontline clinicians. So they would have had to make phone calls to try and ascertain critical information, which may have delayed care and treatment for patients, or they may not just have been able to get hold of that information, particularly if it was out of hours because perhaps a GP practice was closed. Next slide, please. So this just kind of drills down into the usage of the GM Care record, particularly out of hours. So 30% of the time, the record's being used out of hours. And previously to that data sharing, that information just would not have been available quickly and efficiently for frontline clinicians. Next slide, please. So Guy mentioned the work that we'd done on sharing the information at the Christie, our tertiary referral centre for cancer. So there was the development of what we call a Christie tile. So when you open up the front of the GM Care record, your landing page, depending on your permissions, there'll be a row of tiles across the top. There's a pictorial representation there of that on the right-hand side. So that enables users with the correct permissions to be able to access information about cancer diagnosis, consultants, current care and treatment, prognosis, recent investigations, literally at the click of a mouse. And you can see the increasing access over time and that sustained regular access to the cancer care summary tile. Next slide, please. So this slide is a case study which just kind of brings to life really the benefits of having that information at your fingertips, and lots of patients receiving chemotherapy, either they're taking it at home or they're going to their local hospital to receive chemotherapy, and they've got contact with the cancer centre, the Christie, via telephone line. So there's an example here of Jane who feels unwell and she knows to contact the chemotherapy and cancer hotline for advice. They speak to Jane over the telephone, and because of her symptoms, they advise that she needs to attend her nearest emergency department. And usually there's a telephone call to that emergency department to say, we've just spoken to Jane, she's currently having chemotherapy and we've advised her to come. So that would then usually be a verbal message that would go from whoever took the telephone call to the emergency department reception and hopefully the triage nurse. Jane will arrive and book in. And hopefully all that information, because it's kind of word of mouth or it might be written on paper, gets to the reception staff and the triage nurse who know about Jane's arrival. And the triage nurse can then automatically look at the GM care record, assess the recent treatment and identify how high risk Jane might be for chemotherapy complications and low white blood cell count and being at risk of sepsis, and that enables care to be expedited. You've got accurate information at your fingertips, so you can get blood tests arranged, you can arrange isolation for someone that might be at risk or at increased risk of catching infection. Next slide, please. And this is another similar case study, actual patient case study that was fed back to us from one of our local hospices. And I'll just pause for a minute and just let you read the information on that slide. So we can see there that the hospice doctor that was contacted out of hours for advice about this patient didn't know the patient, but was able to access all the relevant information in the GM care record, even the information from the tertiary neurosurgical service, could quickly identify that admission wasn't the preferred option and could expedite the right care for this patient and her family at home. Next slide, please. So it's a really powerful demonstration about how this improvement gave the district nurse and the hospice doctor that one chance to get it right at the time for that patient and family. And I think they were certainly not in any doubt that without that information, they would have had little choice other than to transfer the patient to hospital, which certainly wasn't hers or her family's wishes. Next slide, please. So this is a bit more detailed information building on what Guy talked about earlier in terms of our specific responses within the GM care record to COVID-19. So I mentioned we've got a Christie cancer tile, we've also got a COVID-19 status tile, and initially that had test results. We've had information fed back through us that was very helpful for clinicians who could alter the mode of outpatient follow-up for patients and may have had a virtual consultation with somebody who might be pending a COVID test result versus them actually coming into an outpatient clinic. And you can see the staggering increase in access to that tile, particularly in the early part of this year. We've also got vaccination status information within that tile now. And on the right-hand side of the screen, that's just an illustration of our COVID-19 home monitoring virtual ward dashboard. So in localities, for patients who have had earlier discharge from hospital so that they can have a short period of home monitoring, you can see at a glance on the dashboard the patients who are being looked after in their own home. You can see the latest oxygen saturation results. You can then drill down into the individual care record for that home monitoring period. And for those patients that are able and want to use an app, they are entering their oxygen saturation information and how they're feeling during that day. It might be once a day, it might be a couple of times a day, direct into an app, and that feeds into the dashboard. Of course, that's got massive potential. Some localities, as Guy mentioned, have started to use it to monitor patients with long COVID. We know there's a huge NHS at home agenda, so the potential to expand home monitoring using a platform and a shared care records, phenomenal. Next slide, please. I think this might be my last one. Yeah, so just another example of how the GM Care Records enabled us to support more vulnerable systems, because we're not just talking about health information, talking about information being shared by our local authorities and our social care providers, so we can see what support people have got in their own home. So that may enable people to stay at home because the out of hours GP is aware about all the packages of care or the ambulance paramedic that's arrived. And equally, it can help plan discharge more efficiently. And we've also got increasing use of our end-of-life functionality within GM Care Record, advanced care planning, conversations about preferred place of death, etc. Next slide. I think that might be my final slide. Yeah, beg your pardon. So if we just pop back to that slide, Peter, that's just to kind of finish off really around the direct care use of the GM Care Record. And we've got a clinical reference group which support the clinical development of the direct care functionality. So that's chaired by our clinical director at Health Innovation in Manchester, Dr. Tracy Bell, and that group initially at the beginning of the pandemic we were meeting weekly because there was rapid development within the GM Care Record. We now meet monthly to review not only from a kind of functionality and improvement for staff and patients perspective, but also from a clinical safety perspective. We review all the new features and functionality that are planned for the care record. Okay, thank you.
Lovely, thanks so much, Paula. And if Guy, if you want to switch your camera back on, that'd be fab. Thank you so much for those presentations. They were both really, really excellent. I won't talk too much because we've got so many questions to get through. So I'll do my best to kind of go through all of them. So the first one up is quite a thorny topic. So it's about the recent spike in patient record sharing opt-out. Has it caused you guys any issues?
No, not particularly that we've experienced in Greater Manchester. I think one of the things that we spend a lot of time doing is actually building trust with our data controllers, and in turn the data controllers building trust with patients, because fundamentally it's interesting. I think patients certainly have an expectation that we're sharing some of the data and that we're making that data available at the point of clinical use. So I'll defer to Paula's more clinical expertise, but I think from my perspective we've not seen a significant dropout in that. But I think fundamental that is that you need to be able to build trust with patients around the use of the data. And I think some of the structural governance that we've put in place with public and patient transparent engagement has been fundamental in us helping to build that trust and therefore avoid that specific challenge at scale in Manchester. Paula, anything to add?
Yeah, I think just a couple of points really, just to echo the fact that patients do expect us to know about their information, and they're shocked that they have to keep repeating the story again and again. And for some patients, for example, those with mental health problems, that can be really distressing. So, you know, we've got kind of ethical responsibility to make sure that we're sharing information. And we've currently got a big citizens engagement campaign. I won't be able to Peter might pop in the chat the web address, GM We Are Better Together. So lots of information there to be really transparent with the public, that having your data in there enables your care to be quicker and better and safer, but also from a secondary use perspective and the research that Neil's mentioned that we'll be able to do on populations, it's going to improve the health for everybody in GM. So that's, you know, kind of our stance with patients, but to be very clear that they have got the opportunity to opt out if they don't want to share the data.
Yeah, fantastic. I think it's always about communication and trust. I think those are always the buzzwords when it comes to these types of things. I think this is sort of on a similar sort of vein. Nick's asking what happens after the 30th of September, when the control of patient information notice, which has opened the government's permissions to make the care record possible, expires?
So I think the coping notices have been extended beyond the 31st of September to March. So that's sort of point number one. Point number two is the reason why we've been through the set up the fundamental governance structures that we've done and engage all our data controllers and in turn our patient and public representatives is to ensure that when the coping notice expires, that we continue to maintain data sharing. So in the process, we're currently running a public and patient engagement and marketing campaign around data sharing across Greater Manchester for exactly that purpose. So yeah, we're confident that at the end of the coping notice, we'll have the capabilities to maintain the data sharing across Greater Manchester because of the foundational building blocks that we've put in place and because of the public and patient engagement process we're going through at the moment.
Yeah, I could just add another point. We've also undertaken some benefits work to be able to share across the system some of the benefits that we shared in the slides today, but some more kind of detailed work. And we're also just about to embark on a really ambitious programme over the next 6 months to really quantify the quality, safety, efficiency, some of the fiscal benefits, because you're not having to repeat investigations because you can see the test that was done in another hospital yesterday. So that as well will create, you know, also support the case for continuing to share data.
Another question we've had from Barbara is about whether the Greater Manchester shared care record feeds in, to the NHS app. Does it link up in any way at all?
Yeah, so it will do. So we're currently in the process of finalising the move to the cloud. So I mentioned that we need to move from on-premise to cloud. That is due to be complete by the end of October. Once we've got to the cloud, then we've got the ability to roll out a patient-held record capability across Greater Manchester, which basically enables all patients to have visible access to all that particular data. And we're currently working with the integration with the NHS app, with that patient-held record app. So it will be sort of seamlessly integrated with the NHS app when we deploy that capability towards the back end of this year. And
then will that mean obviously that people can see their records, kind of like medication records, all that kind of stuff, kind of they'll have access to it by that way? Yeah,
absolutely. So you'll be able to launch in from the NHS app. Well, you'll be able to authenticate using the NHS app, and then you'll be able to launch into the components of that you see in the GM care record, which will give you access to both your medical history, your appointment day details, and so on and so forth.
Yeah, because that links in. So we've had kind of quite a few questions surrounding whether patients can see this data, will they be able to view it? So can they do that now, or will they have to kind of wait until it's fed into the NHS app?
They can't do it now because there was a technical dependency about us moving to the cloud to enable us to deploy that patient-held application ubiquitously across GM. So that's one of the key dependencies. And tactically, what we've done until we've actually made that technical move, then for the specific apps that we've deployed, like the Covid Oximetry, the heart failure care plan, and the maternity app, we've done we've established a tactical instance in the cloud to enable that bi-directional capability. But that's been for specific cohorts of patients. So the ubiquitous deployment of a patient-held record capability, so across the whole of GM, will be available, as I say, towards the back end of this year.
Paula, did you want to add anything or?
No.
This question, the next one that's got up, is quite a long one, so I'm just going to have to make sure I'm reading it correctly. So what were the main technical architecture challenges with particular reference to access to NHS digital national services, especially to keep the enterprise master patient index up to date? I'm not sure if hopefully that makes sense to you. So I'm guessing it's just what were the challenges with I'm guessing the overall architecture of the record, because obviously it's quite a big thing to kind of create.
Yeah, no, great question. So for those technical people technical on the call, yeah. So the electronic patient index, master index within our GM Care record is actually synced into PDS for patient tracing. So that integration is there. To be honest, it's a relatively straightforward integration, and that's well proven and well tested. So that's not necessarily been an issue. In fact, there hasn't been that many significant architectural and technical challenges. There's a level of complexity as we move from on-premise to the cloud, because we have to actually switch a lot of the network routing from 500 GPs to a different place. So we need to make sure it's not particularly technically complex, but you need to make sure you do it correctly so it works. But no, by far the most complex is actually the information governance and building that trust as opposed to the tech.
It's such a challenge. I think you have to get the balance right, don't you? It's a complicated thing. Another question from Nathan. So he's saying that in my previous trust, we had a population health portal with patient level data flowing from primary, secondary, community and social care, as well as ambulance, 111 and prescribing information. Does the GM Care record provide any of the below? And if so, how can it be accessed? So it's risk stratification, or frequent attenders, and geo-analytics to track all the cohorts admissions, which could be linked to include overlay and demographic data. So does it include that, I think is the main question.
I think the simple answer is yes. So the data feeds all flow into the GM Care record for direct care. They all flow in. The list that you just talked about. From that, all the data then is essentially replicated into an analytics version of the GM Care record. And that analytics has sort of three types of data set. It's got patient identifiable data, it's got pseudonymized data and anonymized data. So that then determines, who accesses is that. So if you're doing service planning, then you need to have a look at perhaps the pseudonymized data, because you don't need patient identifiable data. If you're doing a research study, you probably just need the anonymized data. So we've got various different layers about that sort of data access, and that enables us to slice and dice the data to look at different cohorts to be able to do proactive case finding. Yeah, so the answer is yes.
Lovely. I know we've obviously touched on patients getting access and inputting into the GM Care record, but there's also someone's asked whether patients and carers can access it. So is there a functionality for someone to have their carer sort of give consent, or is that something that's kind of maybe a bit farther down the line?
There will be, as we release the patient held record capability.
Yeah.
So that comes along with the ability for patients and their carers to engage. So not yet, but in December. Yeah.
There is functionality in the record for integrated care and support plans, so the things that matter to the patient, and particularly with the Frailty care plan, we will be developing functionality so carers can also input or support their loved one in entering information into the record.
Lovely. Thanks both. Pippa's got a question for you, Guy, and it's saying about how was the IG framework realised? So they're saying it certainly must be better than the NHS publication on Tuesday this week. No comment on that from me. But yeah, it's about how did you kind of put together the IG framework?
So how best to answer the question? So the framework is technically quite it's relatively straightforward in terms of filling in the overall structure of the documentation that needs to be done. The heavy lifting is getting all the 600 data controllers to actually sign that data processing agreement. So, and look, if anybody's got any, if we can help in terms of providing any of those templates that we've used, more than happy to share those if that helps. I've got an IG expert, Jenny, that works for me. So there's probably some more nuance into that question that I'm probably not picking up because I'm not a detailed IG expert. But if there's any help that people need to look at some of the templates we've used, happy to share.
Thanks, Guy. Another question from Rich is saying, how is the data flowed into the GM Care record? Is it overnight extracts or in real time?
A combination of both. So the GP feeds flow overnight. The secondary care data, which is the ADT attendance data, as an example, flows in real time. So it depends on which particular data feed that we're talking about. Combination of both.
Thank you. And then another one from Yash is asking, what platform is the GM Care record hosted on, and what are the integration challenges given a lot of the data is being collected and processed? So I'm guessing the platform's Graphnet, and then about integration challenges. But if you want to expand, I'm answering your question for you. I don't know why.
So we partner with Graphnet in terms of the solution provider that provides that capability. The integration challenges, from a technical perspective, there's not many integration challenges as long as the biggest one is as long as you've got somebody's NHS number, then you can link the data together. The thing that we're approaching now is how you get consistency of the data that's being moved. So let me give you a good example. So pathology data is a really good example. So if you do a PCR test for COVID, then depending on which lab you go to, so that all that information comes into the GM care record, and a clinician can look at that and go, is guy positive, he's had one at MFT, Manchester Foundation or Trust or Salford, they can read them. But the way that data comes in, because the labs send it in a different way, appears on the screen in a different way. So when the clinicians look at it, it's obvious that you've had a PCR test and whether it's positive or negative, but from a data perspective, you can't actually say that they're both semantically the same. So we're about to launch a big program of work around semantically aligning the data standards across GM. And to be honest, the heart and soul of that is agreeing those pathology standards with the lab technicians. We can do some very easy things around matching. This field equates to that, but in reality, what you want to be able to do is agree some harmonized coding across GM. So that's our next big program of work.
It's just been pointed out to me that I've missed the second question that's been bumped up my list by Oliver. Apologies, Oliver. So the question is why are we making Manchester Care Record, Northern Care Record, London Care Record, etc.? I think basically what is I'm guessing what he's trying to say, I'm hoping, I'm sure he'll tell me if I'm wrong. What are the benefits of having a Manchester sort of centric care record? I'm guessing it's probably aimed at both of you, really.
Well, yeah, I mean, it's a great question. Ultimately, you just want one care record across the whole of the UK, right? And look, that's the holy grail that everybody's looking for. The challenge is there's some technical and IG complexity to that, which makes it incredibly difficult. So from a technical perspective, I think it's probably easier to connect some of that data together in terms of sharing that data. And that's where the Leica programs were very much sort of targeted. So I think that problem's not insurmountable. I think the much more of a challenge is, the heavy lifting that we've done around the 600 data controllers to enable data sharing across GM for the 2.83 million patient records has been extreme in terms of the collaboration we need to drive. So if you then, say that you're going to share Guy's record down to somebody else down, in another conurbation, the first question is why do they need to see it, and what's the level of frequency by which they need to see it, and so therefore the issue is less technical, more around the IG, but absolutely you want to be ultimately get to Guy's record across the whole of the UK rather than the GM care record. So we're trying to solve the problem that we can solve in our region, if that makes sense, but very much willing to work with other regions in this space.
Oh, sorry about Ola. Just I said, what is? I guess a follow-up question is, what is so special about Manchester Care Record? And should we all use Manchester Care Record or a different one? I'm guessing that's if they live in Manchester.
Well, I mean, from our perspective, I mean, what's special is it's provide a consistent set of data that's available at the point of care across multiple conditions and care settings. That's where the magic happens. We happen to use Graphnet for that, which is which we're really supportive of. It's been a great product for us to do it, and other regions are doing the same thing with different technologies, which is equally as good. So yeah, I mean, the special nature, is it special? I think in GM, I think we're pretty advanced in terms of the amount of data that's going into that GM care record. I think we're pretty advanced in terms of alignment across the system, both with social care, primary care, secondary care, about the population of that. I think we're pretty advanced in terms of the usage of that data. I think we've got some way to go to drive the adoption of that further, and Paul is just about to launch a program around it. And I suppose the other bit is that, aligned to the conversation that the video from Neil's, is there's a huge amount of value in the insight that's in the data. And essentially, I suppose our magic sauce is our ability to bring the power of the 4 universities across Greater Manchester plus the industry to bear to drive insight into that data and then more importantly inform about how we design and change clinical pathways. So our magic sauce is less about the platform. It's more around the power that the platform gives us in terms of visibility of data for decision making, but the power for us to understand what's going on across our system and then redesign those pathways to enable clinical care.
Thanks, Guy. Moving sort of away from that, Jerry's had a question. Has any thought been given to a single patient citizen identity solution to extend from the Great Manchester Care Record, say into things like welfare and housing? I know that's kind of something that's been, you link it further than beyond healthcare, so to speak, and because healthcare obviously reaches into so many different parts of society. Is there kind of any plans to move it into those sort of areas?
I think we all recognise that most of our health outcomes are actually affected by other things than health and the social determinants. So absolutely, the challenge really comes about the information governance. So you take a good example. So I think somebody raised a question around data sharing. Would we all be happy that the police had access to your healthcare record? And the question is, maybe, and maybe useful, but the moment you're into that territory, it poses some really interesting privacy sort of questions. So what we're certainly doing at the moment is making sure that health and care we've got our own house in order, and then we're saying, okay, so how do we bridge into those other areas? Reckon there is direct connection, but you really need to be clear about the use case that you're using to really drive the value from it, if that makes sense. So technically it's relatively straightforward to do, but there's lots of minefields from an IG and ethical perspective you need to overcome to enable that to occur.
Yeah, I think I could just add that certainly there's very powerful data that's not health and care data available that would help proactive management. So people, for example, who have assisted bin collections are perhaps frail and vulnerable, but unknown necessarily to services. And if we had that extra bit of information, an MDT, you may be visiting that person earlier and preventing a fall, etc. But there's ambition there to look at that level of detail. But as Guy said, we've got to get our house in order in terms of people having real confidence in the scrutiny that we're putting into the IG at the moment to make sure it's secure and safe. Yeah. Thanks,
Paula. Question for you, Guy, is talking about the cloud. So with your move to cloud to facilitate the ongoing nature of your digital transformation journey, what are your thoughts around Greater Manchester having a multi-cloud strategy that is not prescribed by the software as a service relationship you already have with Graphnet? And does things like Google Cloud have a part to play with ongoing kind of data strategy?
Look, my personal view of cloud is that we need to be all in cloud in terms of adoption of cloud services. I think there is, I think the bigger challenge with cloud is how we address some of the major scale adoption challenges, which is actually how do you deal with the capital and revenue challenge? Could we get rewarded by capital, not revenue? How do we deal with the double bubble cost of transition from our legacy to the cloud? How do we deal with the skills and talent capability required to re-engineer applications to make them cost effective in the cloud? Because you just lift and shift, it can be more costly. So there's lots of elements. We're actually doing a piece of work coincidentally around that particular piece, but I'm really supportive of the cloud, not least because you have to you stand on the shoulders of the billions of pounds that cloud providers are putting into their investment space in that space. And if you go and buy something off the shelf right now and put your own data center, you're immediately not investing in terms of leveraging that investment. So there's a huge amount of benefit to go into the cloud, but it's quite complex for a variety of reasons to do that pace and scale. But we're working on that in GM in a different program I'm leading.
Thanks, Guy. I know sort of very conscious of time. If it's okay with you, I'll ask a few more questions. We'll run over slightly, but just everyone else who's got their questions, they will be put to Paula and Guy, and they can answer kind of via sort of email or something like that. But I'll ask a few more because obviously there's so many coming through. So another question is about: do you have more than one supplier, or is it just primarily Graphnet?
In the GM Care record, it's predominantly Graphnet. Yeah.
That one was nice and easy. So another one is, as patient flows can be outside the immediate region, Cheshire East, for instance, how will this be developed and when?
So yeah, I work very closely with my counterparts in Cheshire East and Lancashire, South Cumbria. So at the moment, we are for example, the information. If you take NWAS as an example, it says both those three. NWAS have access both to the GM care record and to the equivalent of both those two others. So they're at least from a visual perspective, be able to understand it. There is a piece of work that we're doing around understanding about how technically we can build those things closer together, so it's much more integrated. But the challenge really is, again, it's just the complexity of the information governance and the flow around those elements. I absolutely agree. So it's the complexity of the edge case, if that makes sense, and how much you spend on that edge case versus, the effort required to get there. So technically, we're doing something around it. It's a program underway. The issue really is getting the IG right.
Lovely. I'll just do a couple more, and then I promise we'll wrap things up. But what sort of role-based access do you use to ensure the right people can access the information about their patients? I guess that's quite a key thing, when you've got sort of sensitive information.
Yeah, I can attempt to answer that. Although Jenny Spears, our IG expert, she's on leave actually this week, or she would have joined us today, because we always get the IG questions. So we are, and Jenny's involved in some national work around role-based access, but Jenny is leading a piece of work just to understand what the current status of the role-based access is. Guy mentioned at the beginning of his slide, we're moving to one contract across Greater Manchester for the GM care record. Prior to that, it was each locality had their own shared care record with their own contract and their own decisions about role-based access. So it's scrutinised at a locality level at the moment through their normal IG routes, but we are doing a piece of work to understand what that looks like across GM and see if we need to do any work to kind of standardise that in light of the work that's happening nationally. So I hope that wasn't too vague.
Thanks so much, Paula. I'm just going to do one final question. I think it's quite a good one to end on, because I think it goes back to this whole thing about patient consent and being aware. Because I'm sure a lot of people are aware of the whole thing surrounding GPDPR. I think that's the right acronym, and there was criticisms that there wasn't enough information fed to people about it. So Kenneth's asking, are all patients aware how widely their data is shared, and if so, is this achieved individually? So kind of how are you making sure patients are aware that what's happening to their data, I think, is probably the overarching question there.
Yeah, I can start that, Guy, you might be able to add, but it hinges really on the campaign that Peter, who's been managing our slides, has been leading with Jenny. So, that's through a dedicated website, through social media, through privacy notice that are available in all health and care settings that patients have got access to, through visiting patient forums. I mean, we haven't got to the level of kind of leafleting every resident in GM to let them know, but we have started an extensive campaign to let patients know, and we're looking to our colleagues in primary care really to help us with posters and leaflets to let patients know about their data.
Did you want anything, Guy, or you're just nodding?
No, I think Paula's nailed it. I know Peter's closer to it than anybody, so I don't know if Peter wants to add anything.
Fabulous.
Just very quickly, sorry, just to jump on. No. Yeah, I mean, in fact, next week there'll be a lot more to come out about the GM care record for the public and information, and also, supplementing what Paula's mentioned is we provided toolkits for communications to all health and care organisations across Greater Manchester to use on their own channels as well. So this is whether it be on websites, social media, posters, leaflets, etc. So we've circulate that to all GP practices, all CCGs, acutes, etc., to make use of on their own channels. And also we're supplementing it with a paid-for campaign as well. So that's about to happen and is very imminent. Sorry to jump on.
No, thanks so much, Peter, and thanks for doing all the slides. You did a great job. I think we've gone way past 1:30, so I think we're going to have to wrap it up there. Anyone who hasn't had their questions answered, as I mentioned before, we will send them over to Paula and Guy, and they can respond in sort of the best way that they can. But thank you to everyone who's tuned into today's webinar, and thank you so much to Paula and Guy for giving a fantastic presentation. It's been really, really useful and kind of great insight to what you guys have been doing over the last year. I'm just going to do a very, very cheeky plug for digital health events. If you go over to our website, we've got so many more webinars and fantastic kind of events coming up. We've got Autumn Leadership Summit in November, so please head over to our website and register for everything. So that's my plug over. So that concludes today's webinar, and thanks again to everyone who's joined us today. Thanks, Paula, and thanks, Guy.
Okay. Thanks, Hannah.